for this year's BioCAS conference as well. With that, Hossein, the podium is yours. Thank you.
Yes. Okay, this on? Great. Okay, thanks for the introduction, Pedram, and good morning, everyone. As mentioned, well, my tutorial today is going to be on closed-loop neurostimulation for patient-optimized treatment of intractable epilepsy. This is a topic that has been investigated by the community, by the BioCAS community for more than a decade now, and I'm hoping to provide an overview of the state of the art, talk a little bit about current challenges and future trends in this field. I'm going to start my talk with some introductory material. I'm going to start talking about neurostimulation, what is it and how it can actually help us with epilepsy, the current state of technology, what are the commercially available solutions in the market, and basically what does it take to design closed-loop neurostimulator devices, which could include blocks for seizure detection and responsive neurostimulation. In the next part of my talk, I'm going to talk about fundamentals of seizure detection and performance evaluation. How do we actually evaluate seizure detection algorithms performance in terms of software and like for software implementations and hardware implementations. Then I'm going to talk about feature extraction and how to select them and different kind of classification algorithms that have been reported in literature and their on-chip implementation. Towards the end of this section, I'm going to talk about recent and future trends in this in the seizure detection and some final thoughts and discussions on comparison of these different works. Toward the end of my talk, I'm going to go back to responsive stimulation, talk about some of the fundamentals, some discussions on the safety, and then basically end that with a discussion on patient-optimized stimulation. So what is electrical neurostimulation? Simply defined, it's manipulating neuronal activities of the brain using electrical pulses. This manipulation could be in terms of like basically exciting them or inhibiting them. And the way that stimulation actually affects neuronal activity could be explained in different levels. So at the ionic level, the idea is that electrical stimulation causes redistribution of charged particles, and because of that, we're going to, which is going to create electric fields, which in turn results in manipulating the opening and closing of channels that we have on neuronal cell membranes. And these openings and closing at the cellular level result in generation of action potentials or spikes, the way that our neurons actually communicate to each other. And that is how electrical stimulation, by generation of these, by artificial generation of these spikes or action potentials, it could actually influence our neuronal activity. At the network level, there's so many different theories. Two of the popular ones are mentioned here. There is synaptic filtering theory, which basically suggests that electrical stimulations or the neurons and connections that are affected by electrical stimulation hinder the propagation of certain oscillations within their network. And information lesion suggesting that basically by electrical stimulation, we are basically overwriting the intrinsic activity of our brain. Of course, these are all theories. And this is an active area of research. They only explain the short-term impact of electrical stimulation, and the long-term effects have their own theories. It's a little bit outside of the scope of this tutorial, so I'm going to leave it at this point. What is important for us is many different evidences, like this one that I've shown here. Well, I don't think I can actually point to anything with this angle, but with this picture that I've shown here, which is a spectrogram of a brain recording for a few minutes. And you can see that on the x-axis we have time and the y-axis we have frequency. And you can see that when the stimulation is turned on, the certain oscillations at certain frequencies are actually disappeared or suppressed. And then when the stimulation is turned off again, the oscillations come back on. So what is important for us is that we know it works from empirical data, and we have many different evidences of that. And basically, because of that, we're interested in neurostimulation. So it's not a new method. It's not a new technique. It has been around for a few decades now. It is indeed the standard of care for patients with treatment refractory motor circuit disorders such as Parkinson's disease, dystonia, and essential tremor. It's highly effective. It's widely used. In fact, there are more than just in the span of 9 years, and only in the United States, there has been more than 30,000 surgeries to implant only a specific type of neurostimulator, which is called deep brain stimulators. The caveat being, well, it still remains very resource intensive and mostly used in high-income countries. Perhaps the best way to actually see the impact of a neurostimulation is to actually see how it affects patients' life. In this video, you can see a patient's off medication, a Parkinson's disease patient off medication. And you can see when deep brain stimulation is actually turned on, a lot of symptoms of Parkinson's disease are actually suppressed greatly. So motivated by many examples like this, people looked into the use of neurostimulation for other neurological disorders, including epilepsy, which is the topic of our talk today. So what is epilepsy? It's a common disorder characterized by recurrent and unpredictable seizures. It's quite prevalent. 1 in every 100 people are dealing with it. And well, the good news about it is that close to 70% of patients with epilepsy can be treated with pharmacological solutions today. So that's the good news. But then, well, for the other 30%, they have to actually deal with symptoms such as anxiety and depression, physical injury, and, well, unfortunately, sudden death due to epilepsy. And the idea here is that with neurostimulation, we're hoping that we can provide a treatment alternative for these patients, for this section of patients. What is seizure? It's simply defined. It's a temporary dysfunction of the brain consisting of 2 main characteristics, which is basically its excessiveness and, well, it is asynchronous neuronal activity. So in terms of duration, it could be a few seconds to a few minutes. In terms of frequency, it could be as bad as a few times a day to as good as, well, once every few months. And there are different types of seizures. We have convulsive seizures, which means that you can actually visibly see the patient's muscles jerking. And then, well, we have absence seizures, which is the absence of those kind of symptoms. And we have also focal and generalized epilepsy, one of them affecting only a specific area of the brain, and the other one, well, affecting pretty much everywhere in the brain. Due to its temporary nature, studying seizures and studying epilepsy requires methods that have high temporal resolution. And that is why EEG or electroencephalography has been the method of use for many people who are working in this domain. So if you look at the EEG signals, in this case, from 2 different channels, EEG signals for a patient who has epilepsy and during a seizure event, we can see that there are different periods. There's a period shown in red, which we call ictal, which is when the seizure happens. And then there's the yellow period, which is pre-ictal, immediately before an upcoming seizure, which is a very important period for us, as I'll talk about it later. And then there are interictal periods, which means, well, any other time or like between seizures. And then if you look at another example of these EEG signals during a seizure event, we can see that the manifestation of seizure, or basically the seizure manifestation in EEG, you can see that it actually is very different between 2 different channels or between 2 different patients. And that's one of the reasons that like seizure detection is generally a challenging task. Neurostimulation has been used for epilepsy and for suppressing seizures for some time again. And the idea here is that we're trying to attack those main characteristics of seizures. First, the idea is that like we want to actually this stimulation to activate inhibitory populations to attack that excessive characteristics. And then also we want the stimulation to be able to disrupt the synchrony between different parts of the networks across the brain. There are non-invasive and invasive methods. You can see examples of them here. With the non-invasive, we have transcranial magnetic stimulation and transcranial direct current stimulation. There are, for now, like there have been clinical trials on them, but then there are the experimental phase. And then we have invasive methods that are much more or far more advanced in terms of getting the FDA approvals. We have VNS, which is basically implanting. These are fully implantable devices. They implant the device on the chest cavity, and the device delivers pulses to a bundle of nerves called vagus nerve in the left side of the patient's neck. This has been around for more than 25 years and has received approval for focal epilepsy. And then we have deep brain or intracortical stimulations that are basically, one example is shown here. Again, the implantation is similar, but the application point of stimulation is different. They also have received FDA approval for some time now. In terms of, so those were the modalities of stimulation. In terms of strategies, we could have open loop and closed loop stimulation. So in terms of open loop is pretty much similar to what the pacemakers do for the heart. So that's why we call them pacemakers for the brain. The idea is that we are stimulating with fixed pre-programmed set of pulses without any kind of monitoring brain neuronal activities or any physiological activity of the body. And the idea of the closed loop is, well, we want to monitor brain neuronal activity and only trigger stimulation if we detect an upcoming seizure. So because of that, and considering the infrequency of seizures, the infrequent occurrence rate of seizures that could be at worst case a few times a day, you can imagine that with closed loop, ideally, we're hoping to have less number of stimulation episodes per day. As a result of that, it is considered to be more safe, more energy efficient, and also they're actually considered to be more effective. And the reason that the reason for that is the critical importance of timing of stimulation for seizure suppression. So let's talk about that. So it turns out that it is very important if you want to stimulate and to suppress a seizure, it's very important to do it before the seizure is fully formed. Here you can see two different episodes, two examples. On the left, we see an example that after the seizure onset, when the seizure starts, several seconds after that, we start doing stimulation. And despite doing it for 5 times, we are not able to actually stop the seizure, and the seizure is actually fully formed, and well, the stimulation is unsuccessful. While in the example on the right, we can see that stimulation is actually triggered shortly after the onset of the seizure, and it could actually successfully suppress. More statistical data has been shown in this work from 2016, where the authors actually try to, they use a statistically significant number of rodents with epilepsy animal model, and they try to group them into no stimulation, open loop stimulation, and closed loop stimulation. And they showed that with closed loop stimulation, we can get a lot more reduction in terms of number of seizures per day compared to open loop. And this is due to that timing and importance of timing of stimulation. In terms of commercially available closed loop devices, we have closed loop devices for VNS or vagus nerve stimulation. This one is from Cyberonics. Now it's called Livanova. It has an auto steam feature. It doesn't do closed loop stimulation exactly the way I described before. Basically, it doesn't trigger stimulation upon detection of an event. It's more like an adaptive stimulation, meaning that it tries to increase if it sees that if it detects tachycardia, which is a medical term for heartbeats of above 100 beats per minute, it tries to actually increase the magnitude and frequency and duty cycle of the stimulations to actually make the stimulation more effective. We have closed loop deep brain stimulators or cortical stimulators as well. This is a device from Medtronic. It records brain signals or neural signals from 2 different channels. It can actually store some spectral information for those signals, and it can actually stimulate as well. Based on my knowledge, to the best of my knowledge, this device is still, although it has the capability to be closed loop, it still is not a responsive device, and it doesn't trigger stimulation upon detection. And then, of course, we have the NeuroPace responsive neurostimulator, which is probably the most famous device for a closed loop stimulation, and this most widely used clinical device for neurostimulation. Its implantation is actually quite different. It's actually implanted in the scalp, and it has both surface and depth electrodes. It records neural signals from 4 different channels and applies certain feature extractions to the recording signals. These feature extractions are, well, quite simple ones: line lengths and low magnitude, high frequency activity detection and half wave detection at a specific frequency. And then, well, if it detects if the combination of these features that are extracted, if the magnitude of those features are above a certain threshold, it tries to trigger stimulation. And it has 8 channels for stimulation. The stimulations are generic and pre-programmed. You see the example pulses, frequency, duration, and duty cycle here. Well, due to this kind of rudimentary algorithm that they use for detection, which is basically based on thresholding, you're going to see more complicated, more sophisticated algorithms later on. Due to this algorithm, they could have a lot of false positives. Actually, in a report that is cited here, we see that some of them might have several thousands of stimulations per day that are basically false positives, not related to detection of seizures. That being said, this device has gone through a long clinical trial with basically many different patients and in different epilepsy centers across in the United States, and has shown very optimistic results in terms of reducing the efficacy in reducing number of seizures per day. So they actually show that although there are a number of patients that have had increase in their number of seizures, the majority of patients, 73% of patients, have seizure reduction of more than 50%. So motivated by, the efficacy of these closed-loop neurostimulators and the fact that we have a lot of room for improvement in terms of what is commercially available, a lot of people have been working on, so this area of designing and development of closed-loop neurostimulators has been a popular area of research. So these devices, as shown here, they have, at the very least, they have 3 blocks for recording, for processing, and for stimulation. And generally, because they are supposed to be implantable devices, they generally have also blocks for wireless communication and wireless power delivery. Now, a bit about recording. So generally, we can record signals or electroencephalography or electrical activity of the brain from different layers, or at different levels. So we have scalp EEG, we can record from the surface of the brain or the cortex layer, electrocorticography, and we have intracortical EEG recorded with these depth electrodes. And as you can actually see, as we go from the left to the right, we get more and more invasive and we lose our spatial coverage. We go from whole brain coverage to just covering a few square millimeters. But at the same time, we are actually achieving more and more bandwidth and, more importantly, more and more spatial resolution. So all of these signals have been used for seizure detection, and we are not going to basically talk a lot about the recording in this tutorial, other than perhaps this slide where I'm going to talk about a little bit about what is required for recording. So generally, there's a range of amplitude and frequency that we need to be able to cover. We want these recording front-end circuits to be very low noise, high input impedance, and high CMRR and PSRR. The circuits should be actually dealing with certain problems such as DC offset between the electrodes, as well as basically artifacts which are unwanted large signals that appear on top of the EEG due to movement of electrodes or the stimulation themselves, as well as crosstalk. So they need to actually be dealing with all of these kind of problems while spending minimum area and power consumption. Of course, just this recording front ends, and talking about recording front ends requires its own dedicated tutorial. So I'm not going to, just to keep the focus of this tutorial on seizure detection and responsive stimulation, I'm going to leave it at here. I'm just going to mention that our group has 2 papers on neural recording. So if you're interested, they're going to be presented tomorrow, and I encourage you to attend these sessions. Now, let's move on to processing. So the first question that might come to mind is that, why do we need to do the processing on chip? Because, we can actually transmit everything off chip. We have a lot of computational power in a computer, or basically we can send it. So this loop that we are trying to close, it could be done on chip, but we could actually close this loop. The clicker is not working. Let me see if, this thing works. So we can close the loop in a wearable device, in a handheld device. Still not working. Okay. In a stationary laptop and in a cloud. If it works, you can see the importance of computational resources. So that's what I'm trying to talk about today. So we can close the loop at different levels, and the more computational resources we have, the less chance of these things happening, right? So we generally, it's good to actually go off chip, but then you can imagine that, well, this comes at a cost. The expense is that, well, we need to do wireless transmission, and most of the time, the amount of power that we need to do wireless transmission of data off the implant and to outside of the body is a lot more than what we can actually what we need for on-chip processing. The other reason is latency. So this bidirectional communication of sending recording data off the body and then sending the result back might actually result in a lot of delay. And we talked about the critical importance of delay and latency and timing for responsive stimulation. Yeah, this thing, okay. So I might have skipped through one slide. Can we go back one slide? Or oh no, it's good. Okay. So let's talk about seizure detection terminology. So if you review papers, you will see that this seizure classification, sometimes people refer to it as seizure detection, sometimes seizure prediction or seizure early detection. The difference is that, well, when we're talking about detection, the way I know it is that we're talking about detecting seizures during the seizure or immediately before that sometimes. And seizure prediction, you can imagine that we're talking about predicting the seizure, and sometimes it's basically a few seconds before the seizure happens, and sometimes it is basically up to a few minutes or tens of minutes or more than an hour. And then we have early detection, which is basically the term referred to basically detecting seizures a few seconds before their onset. And it's probably the most relevant one for us in terms of like providing responsive stimulation, because that is the best time that we want to actually have, that we have a chance of suppressing seizures if we want to do it for if we want to actually do it with stimulation. The seizure prediction and seizure detection has been an active area of research for some time, again, for a few decades. During the 90s, there were a lot of reports that came out that showed that like they were very promising in terms of basically accuracies that they were reporting. It showed that like they could predict seizures with very high accuracies. But then after the turn of millennium, little by little, more and more evidence actually kind of basically piled up that showed that maybe those results were a little bit more over-optimistic because the methods that were used to actually evaluate those algorithms were not proper. So in 2007, this paper that is cited here, they actually tried to summarize all those problems and show that basically all the mistakes that might have been done in evaluating their seizure prediction. And they actually concluded with a set of guidelines on how to actually evaluate, if you're developing a seizure prediction algorithm, how to evaluate them. And some of those guidelines are mentioned here, that the fact that we need to test on unselected continuous long-term recording that include both pre-ictal and interictal data. Some of those algorithms actually only tested their algorithm on pre-ictal periods of data, which caused over-optimistic results. We need to assess both sensitivity and specificity. I'm going to define these in a second, as well as basically we need to test, of course, the test data by the test data should be unseen by the algorithm. So what are the evaluation metrics, or like how do we evaluate seizure detection or prediction algorithm if we are going to develop one? There are basically metrics that are related to the algorithm or the software, and there are some related to the hardware. Software ones are sensitivity and specificity are the most famous ones. Sensitivity is true positive rate, basically what percentage of seizures we could actually detect. And specificity is true negative rate. Basically, it's 100% if we don't have any false alarms. And then as we have more and more false positives or false alarms, it's going to go down. Other things that are important is latency. We saw the importance of timing. Robustness to noise, so it should work on non-clean data. When we have noise and artifacts in our data, the algorithm should still be able to work. And there are other metrics as well that are defined here, which, well, are somehow related to sensitivity and specificity, but and they're sometimes reported in certain works, but these two are actually the most popular metrics that people use to report the performance of the algorithm. For us BioCAS people, perhaps the hardware metrics are as important, or if not more important. There's energy per classification. So how much energy does it take to actually do a classification with this algorithm, the area, and scalability. So like if you want this algorithm to work on the data from more and more number of electrodes, how does it scale in terms of area and power consumption? The way we generally develop a seizure detection algorithm is that like we generally start with development in software, generally Python or MATLAB, and then we test it on pre-recorded labeled data sets. We test the performance on these data sets, and if we get successful results, we move on to hardware description language conversion and implement it on a general purpose processor like an FPGA, and then basically test it again on data set. At this level, we can actually even test the FPGA-based kind of algorithm on animal models of epilepsy and basically in vivo. And then if everything is perfect and we're happy with the performance both in terms of algorithm and the hardware implementation, we go with an ASIC implementation. Speaking of data sets, these are some of the examples of the most popular data sets that are out there. These are some other free ones that are available online. There's so many of them. But the reason I wanted to talk about them is that there are certain challenges associated with these data sets. The first one is that if you look at the number of, the first one is the large imbalance between the two classes of seizure and non-seizure in these data sets. Unlike some other applications like vision, this causes some problems for us. For example, if you look at the first data set, you see that it has around like 1,000 hours of data in it. And there are only 198 or 200 seizures in that 1,000 hours. And assuming like 1 minute per seizure on average, we're thinking about like 3 hours out of those 1,000 hours, less than 0.5% of data is actually belongs to one class, and 99.5% or even more belongs to the other class. This causes a lot of problems with training and testing data-driven algorithms because we just have very limited number of data points for one of the classes of our data. I'm going to talk more about that when I talk about machine learning algorithms for seizure detection. The other problems is that these data sets are quite diverse and not always perfectly comparable to each other in terms of recording quality, the signal type, pre-processings that are applied to the signal before actually making the data set available to us, and also the type of epilepsy that they have they have recorded data from. Now, let's talk about the processing that we need to do seizure detection. Generally, it's divided into two parts. The algorithm that we develop, the first part is to do feature extraction, and the second part is classification. Let's talk about feature extraction. And to motivate for it, it's good to actually look at EEG data again. So these are some EEG data, scalp EEG data recorded from multiple electrodes across the brain from the MIT data set. And you can see that in this patient, after the seizure onset, we have flattening of the EEG activity for a few seconds. And then right after that, only in two channels, we have beta band, which is between 15 to 30 hertz, beta band rhythms. If you look at the seizure activity in a different patient, we see that, well, it's quite different. So right after the onset, we have these oscillations, this time in the theta band and this time in different electrodes. Again, another patient, and now we see that after the seizure onset, we have these rapid eye blinking artifacts, and then after that, in one of the electrodes, we see these theta band rhythms. Speaking of artifacts, we could have artifacts due to eye blinking, as I showed. We could have oscillatory artifacts such as sleep spindles, or like basically more serious artifacts like due to chewing. And all of these are the kind of artifacts that does happen on the signal, and well, we have to be able to do seizure detection while basically having these in the presence of these artifacts. Now, if you look at signals that are recorded from IEEG or intracranial EEG, the different, like basically electrodes are being implanted here, we see that first of all, the manifestation of seizure is actually quite different. The signal magnitude and the resolution that we can get from the signal is actually quite different from scalp EEG, and also again from this patient to that patient, we have very different manifestation of seizures. So all of these kind of motivate for the fact that, well, we can't just look at the time domain data and put thresholding or like use simple rudimentary algorithms for seizure detection. That might be the reason that we have a lot of false positives with some of the available commercial devices. Oops. Trying to go back. Okay, great. So this is the motivation to extract features, not to look at the time series data and just basically try to detect seizures based on the time series data. So the features that we can actually extract could be univariate or multivariate, meaning that we could extract the features from a single electrode or from multiple electrodes. They could be linear or nonlinear, and both of them have been investigated heavily and no general advantage one of them has over the other one. And we could have time versus frequency domain features. Here's a long list of, no, this is not the one. Yeah, so these are, yeah. So this is the long list of features that I've actually mentioned. I've tried to include in this slide that, well, we see univariate, linear and nonlinear, bivariate, linear and nonlinear, and we see like different kind of time domain and frequency domain features. So this is definitely not an exhaustive list. And basically there's so many other features that have been tried in the literature. But the reason and I'm not going to talk about each one of them one by one, but the reason I'm actually including them is to actually show what kind of work has been looked into or what kind of features have been looked into in the community. I'm going to talk about two of the more popular features that people have tried to extract. The first one is spectral band energy, which is a linear frequency domain univariate feature. And then the other one is the phase locking value, which is a nonlinear phase domain bivariate feature. So the idea of a spectral band energy is related to the EEG examples that I showed. So if we don't look at the time domain and start looking at the frequency domain signals, we see that in the blue trace, we are showing the frequency domain spectrum of the signal during a seizure event. And we see these distinct peaks at a certain frequencies in the spectrum. These are the peaks that are actually absent if we look at the spectrum during an eye blink artifacts or sleep spindle or like basically chewing. So the idea of, so this motivates for using spectral band energy for feature extraction. The idea is that we can actually divide the frequency band that we're interested in to multiple subbands and try to extract the energy of each subband. So this could be done simply by applying different bandpass filters to the signal, and then with different center frequencies, and then extract the energy of the band of the output of the filter and use them as the features. Of course, in terms of hardware implementation of this feature extraction method, we need to consider that, well, we want, in terms of accuracy, we want these filters to be as accurate as possible, which means we need higher and higher orders of filters, which comes at the computational cost. In terms of the other trade-off is basically if you want to have accurate filters, the trade-off between the accuracy of filters at very low frequencies and the latency that it might cause. Yeah, the other feature that basically people have looked into is PLV, or phase locking value. This time, instead of magnitude, we're trying to focus on the phase of the signal. We talked about phase synchrony being, or synchronous activity of neurons being one of the main characteristics of seizures. So here we're trying to actually see if we can actually look at signal from two different electrodes and see if they are actually being synchronous and if their phases are actually locked to each other. So PLV, or phase locking value, is a feature that, well, you can see the mathematical expression of it, and at the core of this expression we see delta phi, which is basically the phase difference between two different the signal from two different electrodes. The way that these are extracted, the PLV is actually calculated. Here's an example implementation of it, where the signal is actually fed to all-pass and Hilbert filters to get the in-band and quadrature components. Those components are actually used using a Cordic processor. The vector mode Cordic processor magnitude and phase of those components are actually calculated, of the signals are calculated, and then the phase difference, and then moving average filters, and then the magnitude of PLV is calculated. And here you can see an example of basically how PLV can actually successfully detect a seizure, where basically we are showing two different channels of recording. And once the onset, and we see that the PLV value goes above a certain threshold shortly before the onset of the seizure. So we talked about two different features, and we showed like basically a long list of different features that are out there. But then how do we choose which feature we need to actually use for our classification? Generally, we don't need to go with one. We can definitely go with more than one feature, and that's actually what people typically do. The way that we can we choose those features is using any of these kind of methods or similar methods, and most of them, one way or the another, they try to do two things at a time. They try to actually choose certain features that are most discriminative in terms of the classification between the two classes of seizure and non-seizure, and also they are basically well, to minimize the redundancy. So simultaneously, we would like to do these things so that we don't want seizures that give us redundant results in terms of like the use for classification. They're kind of redundant. And the second part of seizure detection is classification. So let's talk a bit about the classifiers that are out there. So the classifiers range from very simple thresholding methods that we saw a little bit before, and I'm going to show an example again, to different machine learning algorithms, to deep learning algorithms. And I'm going to try to show different examples of these classifiers in the next few slides and talk about their pros and cons compared to each other. So thresholding is the method that, well, it's probably the simplest method. The idea is very simple. You extract features and then you apply a certain threshold to detect seizure or an upcoming seizure based on that feature or features that we have extracted. It's actually the method of use in NeuroPace RNS, the closed loop commercial device that I talked about. And you can see an example of this from our work in 2016, where as I showed before, at the onset of the seizure, the value of a PLV goes above a certain threshold. And well, in this scenario that I've shown on the left, well, we don't do stimulation, so the value of PLV goes back up again. And on the scenario on the right, after detecting the seizure, we actually triggered stimulation. And once the stimulation is turned off, we can see that the PLV value goes down and stays down. So it is effective, it's simple, it's very hardware efficient, but then it has an obvious error. And the fact that, well, it's a fixed threshold, and you can imagine that different seizures have different dynamics. And if we just go with a fixed threshold for detecting them, what happens is that generally what happens is that we are going to have a lot of false positives or false negatives. So it's not the most efficient, most effective way or most accurate way to detect seizures. And that's why people are motivated to use data-driven algorithms or machine learning algorithms. When it comes to classification, one of the simplest yet most elegant methods for classification or machine learning methods for classification is SVMs or support vector machines. The idea is that we have two classes of data and we're trying to find the decision boundaries separating them, but then we want this decision boundary to have the maximum margin between the two classes. And well, that's why SVM is sometimes called maximum margin classifiers. This is an example of implementation of SVMs for seizure detection. You can see that the authors have extracted the spectral band energy as the feature, and they have fed that to their SVM classifier, and they could get seizure detection with a reasonable accuracy. One of the biggest problems with SVMs in general is what I mentioned before when I was talking about datasets, the huge imbalance in datasets. You can imagine that during training, if you want this decision boundary to be selected properly and with high accuracy, we need to have enough data points on both sides. But if we are actually, well, in the case of epilepsy and seizure detection, one classes of our basic data points is actually we don't have that many data. So, and this becomes even more serious with real-time or real-life implantable devices where, well, if you want to actually get some seizure data or the data for the seizure class, we might actually have to wait days or weeks until we have that data. So setting this decision boundary properly, which sets the accuracy of the detection, could be very tricky with epilepsy and with this huge imbalance in the data set. Techniques that people use to address this are resampling, meaning, well, upsampling the seizure data and downsampling the normal data, or using cost-sensitive SVMs, meaning that giving more weight to the one class over the other one. But at the end of the day, it's an inherent problem with SVMs, which is actually even more serious with nonlinear SVMs, which I'm going to talk about now. So with nonlinear SVMs, the idea is that, well, our two classes of data not always can be separated with a line or a plane in 3D. So what we do is that we use something called kernel trick that takes the data from the input space to a higher dimensional space where we can actually separate the data with a good accuracy using a hyperplane. So this is an example, again, on spectral, an example of seizure detection using nonlinear classifiers or nonlinear SVMs, where the authors use spectral band energy again as the features, and they could get, well, a lot better performance in terms of accuracy and in terms of sensitivity and specificity. The obvious disadvantage of nonlinear SVMs is the higher computational cost. We need to actually perform a nonlinear kernel function, and that causes, that requires a lot of more hardware resources. And that creates an opportunity for researchers in the CAS community to come up with techniques and tricks to actually make that or reduce that computational cost. This is, for example, this is a very simple trick that the authors in this work have used. They actually use a log operator, natural log operator, to basically linearize this. The kernel function that they use is a Gaussian radial basis function that looks like this, and they use a log operator to linearize this function, go to the log domain, do the operations, and then go back to the original domain. And by doing that, they actually replaced a lot of multiplications with just accumulations and saved a lot of energy. Okay, yeah, they showed that with going from linear to nonlinear SVM, they could get slightly, or well, actually a lot better sensitivity. They reduced the false positive rates by a lot, and then, well, in terms of area, at least they're even less than, they're using less than the linear SVMs. So in terms of energy efficiency, they're doing comparable with linear SVMs. This is another work, again, motivated by this hardware cost of nonlinear SVMs. It's from 2020. The authors here tried to use two different chips and do a coarse-fine SVM kind of an implementation. What they did was that in the main chip, they have blocks for recording and stimulation, and they have this coarse classifier, which is a basic thresholding classifier working on the basically average temporal difference of the input signal or the line length feature. And if this coarse classifier, which conceptually is shown here, and basically what they're doing with this coarse classifier is that they're trying to put the decision boundary very conservatively so that they can capture all the seizure data without actually missing any of them, but they don't care too much about the false positives, because if they suspect with the coarse classifier, if they suspect an upcoming seizure, then at that point they trigger this DSP IC where they have the fine classifier, which is, well, burning a lot more power, but it only turns on, I think, if I don't make a mistake, 15% of the time. So by doing that, they could actually achieve more than 2 orders of magnitude improvement in terms of their classification power. Yeah, so this is another work, again, related to SVMs. This time, the authors actually have used different features. As I mentioned, we can have combinations of features applied to the classifier. So they have extracted signal band energy, phase locking value, and cross-frequency coupling. And they also use an autoencoder to reduce the dimensionality of data from 32 channels to just 4. And by doing these, by using these tricks, as well as another trick called EDM SVM, or exponentially decaying memory, they could actually get a lot better energy efficiency in their basically classification in terms of memory consumption and in terms of latency. This is another work from our group that basically we also use different kind of features in this work, and then nonlinear SVM. In this work, we try to actually show the importance of patient-specific feature extraction. We're showing that in this example, for example, for this patient specifically, we see that the frequency band that we want to actually extract the phase locking value actually does matter. You see that in this, for this patient, we see that a certain band of frequency is most discriminated during a seizure compared to other bands for the PLV value. We showed this patient-specific, we showed the importance of patient-specific channel selection as well, showing that for different patients, the seizure to non-seizure energy ratio for spectral band energy is actually quite different. And certain channels, signals from certain channels are actually quite different and quite significantly better than all other channels. So not always using all the signals from all channels is better than just going with a subset of them. And the last thing that we tried to show was optimizing spectral band energy number of bands. We know that, well, we generally we want to avoid higher number of bands because of the hardware cost, but we generally like to have higher bands because it gives us more specificity in terms of spectral band power. But we showed that above a certain number of bands, we don't get a lot of basically performance improvement. And in some cases, actually, it gets worse. Okay. Another class of classifiers, or another category of classifiers that people have used for seizure detection, are decision trees. The idea of a decision tree is actually quite simple. You start from a node and you start answering some yes/no questions until you get to a decision. So with decision trees that are shallow, it's very hard to actually be able to detect to perform a good job with these seizure detection. So people generally try to use ensemble of trees, multiple decision trees that are working in parallel. The way that these trees could work with each other are either through bagging or boosting. With bagging, the idea is that you have a bunch of trees that are in parallel. You train each of them to a randomly selected subset of data, and then basically do a voting. So basically look at the decision made by each of these trees and then vote. With boosting, again, you have multiple trees, but then you do the training in a sequential manner, meaning that you train a tree and then you try to learn, and then you see, well, the misclassification or the mistakes that this tree makes during classification, and try to train the next tree to correct those mistakes. So basically, you try to change the parameters in the next tree to basically sequentially correct these mistakes, and then you train more and more and more trees until you reach your budget for power and area, or you reach a certain performance that you like to get. So the way that you learn from your mistakes could be different. People use, like, for example, gradient descent or adaptive boosting, but then the general idea of boosting is this. And generally with boosting, you get more accuracy, but then as you can imagine, you might actually overfit to the data. So that's the caveat that you need to remember. These are two examples of decision tree classifiers. On the left, we see basically a gradient boosted decision tree classifier, where the authors actually used an interesting architectural idea that allowed them to do on-demand feature extraction, meaning that they didn't need to actually extract all the features before starting classification. And on the right, we have another work where the authors actually used 1024 shallow trees that are working in parallel and are adaptively boosted to perform seizure detection. They also used an interesting idea of bit serial processing to make things more hardware friendly. This is another example of decision tree classifiers where the authors use depth variant tree ensembles, where they're using different trees of different depth, and that allowed them to do cost average training approach, where they could strike trade-off basically between two different optimization tasks to minimize the classification error, but at the same time minimize the power and latency. Generally, what they tried to do was that while they were trying to minimize the classification error, they were trying to make sure that the decisions are made, or the easier decisions are made mostly with the shallower trees, so that they can get less power and less latency. Of course, like anything else these days, seizure detection, deep learning and deep neural networks and convolutional neural networks have been used for seizure detection as well. They have shown better prediction results than SVMs or other conventional machine learning methods. And basically, among different kind of deep neural networks, convolutional ones are actually the most popular ones for seizure detection, simply because they do have these spatial filters applied on the data, which allows them to actually look at the spatial aspect of the recording data, which, well, is great for seizure detection because, well, we know that, well, one of the characteristics of seizures is synchrony between different regions of the brain. So, and it can capture that spatial aspect we can capture that spatial aspect using convolutional neural nets. The input to these convolutional neural nets could be the raw data itself, or it could be the features that we extract from the data. So if you go with the features that we extract, like spectral band energy or PLV or whatnot, what we are relying on is our knowledge of the domain. We're relying that we know exactly what features are the best for this classification task. But then if you go with the raw data, we're really counting on this unique advantage of convolutional neural networks or deep neural networks in general that allows us to not only have patient-specific classification, but also doing patient-specific feature extraction. Basically, instead of extracting the same features for all patients and from all channels, what we are doing is that we're allowing the network to choose what specific features it thinks are best for each channel and for each patient for this seizure classification task. All of these advantages come at the cost or at the expense of computational cost. Basically, neural networks, deep neural networks, especially convolutional neural networks, require a lot more resources in terms of like basically power consumption and memory than machine learning classifiers. There are different kind of techniques that people can use to actually address that, partially at least, but then, well, this is generally a big problem. One of the most popular ways that people are actually trying to address this problem these days is basically using neuromorphic computing and specifically spiking neural networks. The idea is that instead of multiplying the input data by weights and going and using the expensive multiplication, what we do is that we convert the magnitude of the signal into spike trains using different kind of encoding schemes. But then these spikes only have to be accumulated with different weights. So we're replacing expensive multiplication with just accumulation. So that's one advantage. The other advantage that is important for specifically biosignal processing, including seizure detection, is the asynchronous operation of these spiking neural nets. Basically, every neuron, as mentioned, it tries to accumulate all the incoming spikes, and it only generates a spike going to the next layer if the accumulation results passes a certain threshold. So you can imagine that the next layer is going to have any kind of accumulation only if the previous layer has generated these spikes. So, and well, we can imagine that if we go deeper and deeper into the network, we're going to have less and less number of operations required due to this asynchronous operation. Basically, what it does is that it makes the number of computations that we need to do in our network is going to be input adaptive. It's going to be adapted to the level of activity at the input, which is ideal for biosignal processing because of the information sparsity that these signals generally have. In fact, this year we have actually a paper which is going to be presented tomorrow on using spiking neural networks for seizure detection, for patient-specific seizure detection. We do use the raw data in this work for detection, and we have shown that, like, basically we have compared the hardware implementation of the CNN on a microcontroller versus the spiking one on a neuromorphic chip, and we've shown that we can get the energy efficiency comparable to conventional machine learning or patient-specific conventional machine learning methods while getting a lot better latency and very competitive accuracy. Toward the end of this section, I would like to talk a little bit about the recent challenges in seizure detection and then a little bit of discussion on comparison. So one of the challenges that people are dealing with or like trying to address these days is online tuning. So basically, for the past few years, people have thought about the fact that, well, the seizures or the neuronal activity of the brain is generally non-stationary. So whatever classification performed, whatever classifier that we train, we should be able to do online training. We should be able to tune the basically performance or the decision boundaries of this classifier as we go forward and learn from every seizure that we have, that the patient has. So of course, this requires a lot more computational resources because, well, we know that training is a lot more computationally heavy than the inference. And there's a decision that needs to be made, which is basically if we are going to do this tuning unsupervised or supervised. And both of them have been tried. So in this example, we see an unsupervised training method implemented, where the authors use the level of confidence of the detection as an indicator that they use to see if they should include a data point as a true positive or not. So if they have a high confidence in their detection, they just assume that that was a true positive. And by just doing that, they could get basically a slight improvement in the sensitivity, but a significant reduction in their false alarm rate. This is an example of a supervised learning or supervised online tuning where a human input is involved. So the idea is that well, we only are 100% sure if there was actually a seizure and there was a true positive if the human actually, and human could be the patient or the caregiver, could actually tell us so. So what they're trying to do is that they try to basically they have developed a scheme where the human can actually, for example, using a button, they can provide an input to the SVM and tell the algorithm that there was a seizure, there was a false positive, or there was a false negative. And using that, and only by just one new learning point, they have shown that they can get significant improvement in terms of their sensitivity. The other challenge that is being investigated these years is the cross-patient detection. So the idea here is that generally, up to now, everything has been patient-specific. But then what if we don't have enough training data for this patient? It could be because we're doing pre-monitoring. It could be because the patient is coming from an underserved area or community or financially, economically disadvantaged country. So we don't have the personnel or the technologies to actually train the device and then basically do recording and training and like labeling the data for whatever steps is required for training. So can we develop a device that could be trained on so many patients and then could be tested on new patients without actually any idea about their brain activity? So people have actually looked into this for some time now, and it looks like that generally deep learning algorithms are performing much better than the conventional machine learning ones, but of course at the higher computational cost. We did have a paper on this area of like basically cross-patient seizure detection in ISCAS 2023, where we actually showed, again, we had a spiking convolutional neural network. This time we actually extracted certain features, created images based on those features, the PLV and the spectral band power, and then try to use fed those images to convolutional neural net and then a spiking one for inference. And we showed that, well, not only we get better energy efficiency compared to convolutional one, we get a very reasonable sensitivity and specificity for cross-patient seizure detection. In ISSCC this year, there was a paper again on cross-patient seizure detection where the authors actually used a very interesting idea of clustering. So during the training, they tried to actually look into the patient's data during interictal or ictal activities, and they tried to find patterns and basically categorize data from different patients into different clusters. And then using that, when they are dealing with a new patient, what they did is that the new patient goes first through a calibration phase where the algorithm detects what cluster the data belongs to, and then perform classifications accordingly. And using this idea, they could actually get a lot better performance than state of the art. Okay, so towards the end of this section of my talk, I'm going to talk about generally the idea of performance comparison. And I haven't done a lot of quantitative number reporting for different works, and haven't shown any comparison table for a reason, for a good reason, and I'm going to talk about that now. Generally, if you want to compare different classification algorithms, other than the accuracy parameters that we talked about and the energy efficiency and latency, we do like to talk about system level or application level parameters as well. We need to, when we are comparing, we compare if the device is diagnostic or it's for treatment, meaning that it has certain blocks for stimulation as well. Or if it's a patient-specific or cross-patient, or if it has online tuning or not. And also, of course, we need to mention what kind of signal type it has used for its performance evaluation. However, while these parameters are clearly defined, there are certain inconsistencies that has basically hindered the advancement of our field. So I would like to talk about those kind of problems in a couple of slides and how we can actually improve things. So first of all, we saw scalp EEG and IEEG or intracranial EEG and how different they are. So it makes sense that if you're developing an algorithm and we're testing it on a scalp EEG, it should be compared with algorithms that have been tested on the same type of data, or ideally same data set, right? Ideally, we want to test our classification algorithm on different kind of data sets to be able to compare, but then for a fair comparison, it makes sense to use the same type of data and compare to algorithms that have used the same data set. In terms of data set, when we're using a certain data set, for example, MIT data set, the assumption is that we are using data from all patients without any pre-processing, without any basically feeding data continuously without actually creating epochs. We don't do any data redaction or anything else. And if we are doing those things, it's okay, as long as we actually clearly describe it. Because sometimes if you've worked with any of these data sets, you would know that some of the patients are actually easier to, like, basically detection with some of the patients' data are easier than the other ones. And then we see more often than not that a lot of works are actually reporting data or like testing their algorithm on a subset of patients of a certain data set without actually reporting the criteria for choosing those patients. So, or basically, if we are doing any kind of pre-processing, if we are doing any kind of filtering or artifact removal, this should be clearly described, because you can imagine that if we don't remove or remove certain artifacts, or like if we just remove a certain section of data just because we think the quality of recording was not good, it's going to affect the performance of our algorithm. And then, well, it's not fair to compare different algorithms with different data or with different input data. So, and the other thing that I wanted to talk about is about the reporting performance metrics. So we define sensitivity and specificity as these fractions: true positive over true positive plus false negative for sensitivity, and this for specificity. But the definition of true positive and false positive and false negative sometimes vary a lot. People interpret these things very differently. So sometimes, like for example, if I have a seizure that lasts for 30 seconds, I might call it a true positive if I just detect 1 second of it as a seizure, or I might call it true positive only if I, well, detect the entire 30 seconds as a seizure. So this is very different. And then, well, you can imagine that it's going to affect my sensitivity and specificity numbers. So definition of these values, these parameters are very important. One of the works that have actually, so this reference has actually proposed the idea of vector-based and event-based detection, and the definition of these sensitivities, which addresses this issue partially. And then the last thing is about classification and energy consumption. Again, the parameters or the performance metric is actually quite clear, energy per classification. But then what is included in that energy should be clearly reported, because, for example, we could only include the classification power, the power required for classification, but well, some works only report that, some works include the power required for feature extraction, for memory access, or even for recording circuits, recording front-end circuits. So what is included in that number should be clearly described, and also sometimes this classification or energy per classification is calculated in terms of like basically the energy that is basically per sample or per classification. So that's another root cause of inconsistency. This is an example of just to show you this inconsistency. This is an example performance comparison table, and you can see that all of these works are state of the art. All of them are excellent works, but you can see that, for example, for energy efficiency, you can see numbers that are different by 2 orders of magnitude. And this is not because, well, some works are much better than the other ones. It's most of the time it's because of what is actually included in those energy numbers and without actually being reported. And then comparing them with each other in this way probably not going to be so helpful. Same thing with the false alarm rate. You can see that we have per percentage. Some of them are per day, some of them per hour. And the definition of false positive sometimes is not clear. So again, it could be an area for improvement. So towards the end of my talk, I'm going to go back to responsive stimulation and have a short discussion on safety and patient-optimized stimulation. So for stimulation, we can use the same electrodes that we use for recording, or it could be done with different electrodes, could be performed on different electrodes. In terms of mode, it could be a current mode stimulation or voltage mode, using current pulses or voltage pulses. Current mode is generally much more preferred because it allows us to have a precise control of the charges that are being injected to the tissue, no matter how much the tissue electrode interface impedance changes. In terms of pulse shape, we have monophasic and biphasic options. This is an example of a biphasic pulse. As you can see, it has the cathodic phase and the anodic phase. And well, monophasic means, well, just having one of these phases. Biphasic is generally preferred over monophasic because it allows us to have charge balancing, basically, or charge neutrality. Basically, as long as we make sure that the area under the two phases are equal to each other, at the end of each pulse, we're going to have no charge accumulated on the tissue, which is going to be very important for the safety of the tissue, especially in long term. Speaking of safety, another thing that is very important for safety of tissue and safety of stimulation is the density of stimulation. And when I talk about density, I'm talking about spatial density and temporal density. So generally, we want to make sure that we don't violate a certain threshold for coulombs per phase and coulombs per millimeter or centimeter squared. So this is a figure that shows that on the x-axis we have microcoulombs per phase, and on the y-axis we have microcoulombs per, basically the spatial density of the microcoulombs per square centimeter. And you can see that for a certain combination of the two, we might actually, the empirical data shows that we might actually damage the cell tissue. In terms of parameters, so we can set the magnitude of these two phases, we can set the timing of them and the interphasic delay between them, and the repetition rate, right? So there's so many parameters that we can actually set. And well, one of them, the first thing that we want to actually set is, well, which electrode we're going to be stimulating with, because we might have an array of microelectrodes, and we might stimulate only to one of them, or a subset of them, or all of them. So the first thing we want to decide is what electrodes we should use for stimulation. And then the second thing is, well, what parameters do we use? Because these parameters that I mentioned here, what values do we want to use for these parameters? Because magnitudes, if you look at the literature, there are basically magnitudes reported from tens of microamps to a few milliamps. In terms of frequency, there are like few hertz to hundreds of hertz. And in terms of duty cycle, well, we have duty cycles all over the place. So how do we choose these parameters? The current practice is actually a set and go kind of a strategy. Basically, the doctor prescribes a certain fixed set of parameters, and that's it. That's what we go with, and it's basically, it's only adjusted if basically the stimulation has some sort of adverse effects or like efficacy problems, which you can imagine that it's not super efficient or effective, because we did so much for detection. We extracted all of those different kind of features and did so many different, implemented so many different sophisticated machine learning algorithms. And now that we have detected this seizure accurately, we're just stimulating with fixed parameters with almost no patient specificity, channel specificity, or any time variancy, right? So you can see that there is a lot of room for improvement in this field. And well, the bad news is that despite great advancement, the complete mechanism that the stimulation is actually affecting seizures and suppresses seizures is not really known to us at the moment. So we might want to resort to data-driven algorithms again, right? So basically looking at data sets. But then the problem with that is, well, we don't have those kind of data sets. For using a data-driven algorithm, we need to be able to stimulate different patients with different seizure type, with different severity of epilepsy, with so many different parameters, and then record basically the outcome, right? Try to see how the stimulation, how effective the stimulation was in suppressing seizures, right? And well, I've mentioned basically the characteristics of this large-scale, multi-center, long-term kind of like experiment, that we want to change all of these parameter values, and then we want to monitor certain things to see if to have that data set. And yes, if we have that data set, hopefully one day we can use data-driven algorithm to optimize the stimulation parameters. But in the absence of that, one of the techniques that people have tried to use is adaptive stimulation. So the idea is that in addition to closing the loop the conventional way, meaning that recording, processing, and then stimulation, why don't we try to close the loop the other way? Why don't we stimulate and then look at what happened, and then well, look at how effective was the stimulation pulse, and then adjust the parameters accordingly, right? And this is something that has been used for, like, for example, Parkinson's disease for some time. They try to stimulate and they evaluate the efficacy of stimulation in, for example, suppressing certain oscillations in certain bands, right? But then the problem with using this kind of algorithm or this kind of method, the adaptive stimulation with epilepsy, again, goes back to the infrequent occurrence rate of seizures. Imagine that you saw the large parameter space that we have, and imagine that, well, we can only test the efficacy of these stimulations during seizures. And well, at best, we're going to get, or maybe at worst, we're going to get a few seizures per day, and each of them is like 1 minute. So we can only try a few combinations per seizure. it's going to take years, if not lifetime, of the patient for us to actually optimize these stimulation parameters in this adaptive way, right? So because of that, we could look into computational models and see if we can actually use them to optimize the stimulation parameters. There are cell-level computational models for basically evaluating the efficacy of a stimulation pulse at the cellular level. They're not really relevant, and there has been a lot of work on this, but they're not really relevant to what we do, because the kind of stimulation that we do is not really affecting a single cell. It's affecting populations and networks of neurons. So, and then on the other hand, we don't have a really good, accurate model of the entire brain that is precise enough for us to actually optimize the stimulation parameters based on it. So this brings us to network level model or mesoscopic scale models of neurons, such as, for example, Wilson-Cowan model or like Janssen-Red model. These are models that emulate the dynamics of populations of neurons. And well, it makes sense to use them because, well, seizure, after all, is a network level problem. We talked about that. And then also our electrical stimulation is affecting multiple populations of neurons. And well, it makes sense to actually, if you're going to use a model, a computational model, it should be at this scale. So the idea is that we can combine a lot of these population models, excitatory and inhibitory, we can combine a lot of them together and create something called neural mass model, which is basically something that we are going to use as a substitute for the brain. And then if we can somehow fit this neural mass model, this computational artificial brain, to the EEG data of the patient, we can actually make this neural mass model specific to a patient, and then use that to do patient optimized stimulation. This idea has been around for a few years now, and most of the works are in the software. Generally, people are trying to use block diagrams like this, or like systems like this, where they use a neural mass model in the middle, and then they try to stimulate and record from that neural mass model and feed these data to a data set that is used to train a predictive model that is used at the core of a controller called model predictive controller, that basically is designed to predict, to get the neural signal, to look at the current state of the brain and the target signal, which is seizure suppression, and decide what should be the next stimulation parameters. So basically, this has been something that is being currently investigated. Of course, it requires correct selection of neural mass models that are capable of generating seizure and normal states, and also they're capable of receiving external inputs such as a stimulation. It requires high dynamic range recording frontends to be able to stimulate and record at the same time, as well as certain algorithms for stimulation artifact removal. Okay, so let me summarize my talk. In this tutorial, we covered fundamentals of neurostimulation and epilepsy. We talked about commercially available technology and their limitations, and we saw that there's a significant room for improvement here. We reviewed the state of the art for seizure detection and prediction. We saw different kind of the importance of algorithm and hardware co-design. This is where us CAS community could actually contribute a lot, because there is a lot of literature on seizure prediction with algorithms that cannot be implemented in hardware with the budget constraints of implantable devices. We saw cross-patient detection and online tuning as the current challenges in this field, and that they could benefit significantly from more energy-efficient computing. This is something that, for example, neuromorphic computing could help a lot, and we're going to hear from that in the tutorial 3 today. Wide range of features and classifiers are actually reported in literature, and one of the reasons for that, as mentioned, is that it's very difficult to actually sometimes compare different works on seizure detection, and because of that, the community hasn't really converged into a certain type of classifier or certain type of features as the best ones that could be used for seizure detection, because sometimes it's really not apple to apple kind of comparison between these works. Performance evaluation standardization, as I mentioned, could help advancing the field significantly. And of course, better data sets with more data, with multimodal data, and categorized by epilepsy type and severity could definitely help. Towards the end, we saw patient-specific optimization of stimulation and the significant work that could be done in this area. Of course, I just scratched the surface. I didn't talk about everything related to seizure detection and responsive stimulation. There's so many different aspects of these devices that I couldn't talk about today, which I've listed here. I'm not going to go through them for the sake of time. Here are references that used for this work, and thank you. For questions? Yeah. Any questions for one in the back, please? The microphone is maybe, yeah.
Yeah, thank you for the nice tutorial. Yeah, I have a sort of a question, because once I saw like a presentation from a neurologist, and he was saying for epilepsy, when they do diagnostics, there is like tens of types of seizures that they would discriminate between for making like patient diagnostics, because not all epilepsy is the same for any patient. There is like multiple types that you can have and multiple types of seizure a patient can experience. So that is a question, is it, because in this presentation, it was sort of tackled as a binary problem, like a seizure is coming up, you have the seizure, and then it restores the normal neurological state. Let's say if you want to classify, not say just one seizure or not seizure, but like multiple types of seizures, what's like the effect on like all the hardware solutions and all the algorithms that you presented? Does like the accuracy drop considerably? Do we have to spend much more on resources or can like these algorithms be expanded without like hardware cost exploding?
Thank you. Very good point. Indeed, one of the things that I mentioned that could help this field in the end was, well, better data sets. And one of the things that I mentioned for these data sets is we need to have data categorized by the type of seizure and the severity of seizures. Currently, the problem that you mentioned is a real problem, but then data sets don't allow us to actually do those kind of classifications. Right now, we can only work with whatever kind of labeled data set that we have. And the kind of data sets that we have, it's basically the data that is labeled on them is, well, onset of the seizure and basically when the seizure starts and the seizure ends. We don't really have a lot of information on the type of seizure and the severity of seizure. Definitely categorizing data sets would help with that. Not only for classification of different type of seizures, but also for the fact that some of the algorithms might work very well for a certain type of seizure and might not work for certain other types of seizures. And that could help a lot with using these kind of algorithms and using these classifiers for certain patients and not for other patients, right? So like in the clinical aspect of it is actually quite helpful as well. Right now, even without that kind of classification, we're not getting really perfect performances yet. Perhaps the field could be actually advancing. Definitely, that's one of the directions that the field could be advancing towards that. Not only we are detecting an onset of a seizure or the existence of a seizure, we can actually classify what kind of seizure we're really dealing with.
Can I go with my question?
Oh.
Go
ahead.
Thank you. I also want to thank you for the excellent tutorial. I've especially appreciated the critical perspective on comparing different classification and the lack of knowledge on stimulation approaches. So my question is related to this last aspect on using neural mass models to learn how to stimulate, basically. But as you pointed out, one of the problems is making this model patient-specific. And could you maybe elaborate a little bit on how we could do this and how much data we would need from patients in order to make this model specific?
Well, very good question again. So the idea here is that, yes, we are trying to fit the data or fit the parameters of this neural mass model to the patient data, right? Of course, we're not going to do this at the time domain, at the time scale, simply because it's just going to be overfitting the patient parameters, or the NMM parameters to the data. Generally, one way to look into this is that, well, trying to fit the spectral information of the output of the neural mass model to the spectral information of the data, because that shows a more kind of like basically zoomed out picture of the patient's data, right? But you have to really, you need to note that the stimulation parameters that come out of this practice with the neural mass models are not going to be the optimal solution for that patient, right? This is just the starting point. Basically, instead of trying so many different combinations in that large parameter space, we could be basically fitting this NMM to that patient data, and then get a solution that could be a very good starting point when we want to actually apply this to the real patient with the actual brain when we want to do the adaptive stimulation, right? So definitely it's not going to give us the optimal results, but it's going to speed up the process of adaptive optimization over time. How much data do we need? Well, this is very early on. So like basically we are actually working on it, and we've submitted recently, a paper to ISCAS 2024 on this work. We looked into perhaps minutes to, but basically we looked into different episodes of different, like a few seconds to a few tens of seconds to a few minutes, and you could actually see that it does matter. The overlap of the data that the data window that you're actually looking at, and the size of data window actually does matter. The longer you go, there are certain features that you actually extract from the data, certain behaviors of the data that you can extract that you cannot see in the shorter windows, and vice versa. So I can't really answer that question precisely to tell you that how much data do we need. It's not the amount of data that we need. It's basically the question is that what kind of features that we need to actually extract, or what parameters, how do we want to fit our NMM output to real data? In what aspect? Is it time domain? Is it a spectral domain? Or is it any other different features that we want to actually extract from the two to fit together and have high correlation between them? Hope I could answer your question.
One last question by Raf, please.
Thanks for a great talk. So one thought that I was having is, this notion of data imbalance, right? So a lot of the data that I've seen on this kind of work is usually the physician is in the loop when that data is being collected, right? So like the work
in terms of labeling, yes.
Yeah, and actually during the surgery, right? They might be part of, about to, excise a part of the cortex or whatever, and they do the experiments right then and there. So one thought that I was thinking is, can seizure be instigated, right? In order to, to fill in the fact that you only, as you say, 3 hours out of 1,000 hours, right? Can that be done as a means, because the doc is there to get more data of seizure, right? Yeah. So what's your thought on that first? And then secondly, it seems like, if you have data that's already pre-collected, there's nothing much that you can do, in terms of development of algorithms. But if you have the doc in the loop, so to speak, right there with you, then you can do a lot more in terms of making sure that you have the right data to do the experiment.
Very good point. I have two answers. The short answer is I'm an electrical engineer, so I don't know much about like what we can do to trigger seizures, but I'm going to tell you what I've learned. So one thing that they do when, like for patients that are refractory to medication, one of the options before going with stimulation is brain surgery to resect the part. Like for some of the patients, they're candidate for brain resection. And when they want to do that, they actually have to find the focus of the seizure. And to do that, they need to actually record the patient's data to find that seizure location exactly. And then for doing that, they need the patient to be checked in, and they want to record the patient continuously until they have enough seizures to actually be able to tell the focus. So they are motivated to actually instigate these seizures. The way that I know it's being done is a bit cruel. So like they try to go with, whatever naturally causes the patient to have more frequent seizures. For example, they do sleep deprivation. They do optical stimulation. So it's basically the different techniques that people do. I don't know any kind of like manual technique that the surgeon can do to instigate seizure. There are ways to actually do that. Optogenetic stimulation with like genetically modified neuronal cells have been shown to be able to do seizure induction. But what I know is that most of the time they use like normal ways, like, well, no, not normal, like, well, non-manual ways to actually kind of induce seizure in patients.
Thank you.
Welcome.
Okay, thank you very much for saying again.